Hi, everyone. Welcome to another session with Dental Shadowers with virtual shadowing. Thank you for tuning into our session today. My name is Crystal, and I'm part of the Dental Shadowers e-board. And we are so happy to have Dr. Psomiadis with us today, who is a general dentist. And whenever you're ready, doctor, you can get started.
Cool. All right. Well, good evening, everybody. My name is Peter. Dr. Peter Psomiadis. I work in Souderton, Pennsylvania, just in a general practice, family practice. Nothing too big. It's not like a DSO or anything. Just me, my dad, and that's about it. So let me tell you a little bit about myself. So I grew up in Perksey, Pennsylvania. I went to Penridge High School from 2010 to 2014. And then I went to Shippensburg University from 2014 to 2017. And then I did a 3+4 program between Shippensburg and Temple. So then I went to Temple Dental School in 2017 and then graduated 2 years ago in 2021. So just a little about me before I crack into some fun cases. Got a big family. There's 5 of us, got 2 older sisters. One's a primary care doctor for Lehigh Valley. And the other one is a speech pathologist down in Texas. And one's married, and one actually just had our first grandson of the family. So that was exciting. I have a fiance as of last November, and she's over here on the lower right. And then with her, we have our little dog, Addie, which is Pitbull. Love her. And then just like a big hobby of mine when I'm not in the office is golf. So me and my dad and all my friends like to go golfing. And if you ever want to go on a good golf trip, go check out Ireland. It's in that bottom left picture. It's a really, really cool place. Definitely worth it. So let's see my work background. So I went straight from dental school to working with my dad. I didn't do any residencies or anything along those lines. I just wanted to kind of go general. And so since I started, it's been about 2 years of working full time now with my father. So yeah, we're a general practice. We do everything basically from hygiene, restorative with fillings, prosthodontics, crown and bridge. We do endodontics, root canals, ortho. My dad does braces, and then I do like clear aligner therapy, Invisalign or whatever other brand. We do some implantology. So up until I got into the practice, my dad has always been kind of restoring implants. And then when I got out of school, I took a bunch of placing implant courses. So now we do the surgical side as well. We do oral surgery, when we feel like it. If someone needs a tooth pulled pretty bad, like we'll do it, but it's not what our everyday thing includes. We do pediatrics, so we're a whole family office. So we'll see everyone from grandparents all the way down to babies. So we do geriatrics as well. We're open Monday, Tuesday, and Thursday, and then one Saturday a month. So, everyone always kind of laughs at the schedule because I only work 3 days a week. It's a pretty good schedule. My dad kind of started that a while back, and then when I got in, he was like, "Look, just take my schedule and enjoy life." So, he's always about do what you can, help people whenever you can, but also you have to enjoy life because a lot of people, you get burnt out and feel it's a lot of work. So it's just me, my dad, and then my aunt, which is my dad's sister, and she runs the front desk. We have no hygienist or anything right now. When it first started, my dad had a couple, and then it just wasn't working out. So he just decided to kind of take over the hygiene portion himself. And so that's kind of how we run things now. So in that picture on the right, my dad is to the left. It's clearly not on me. So I'm on the right. All right. So, kind of everyday things in our office. When we first get in there in the morning, we show up usually around like 7 o'clock. We'll throw all our instruments in the sterilizer. We have 2 units. And since we have no assistants or anything, so we kind of just do all this ourselves. We got to kind of turn on all the computers, get everything going, check the schedule. There's always calls in the morning for emergencies. We got to schedule them. And then we kind of, prepare operatories for work. So I have my operatory, which is that middle picture. And then my dad has his own operatory. So we're not kind of like bouncing between operatories. There's, only ever kind of 2 pages in the office at all times. I have one, he has the other. And then that other picture in there that's our x-ray room. So, we have a PA machine attached to the wall on the left. And then that big machine in the back, that's our CVCT, pan, and set machine. So we use that every day. It's pretty busy. After all that's done, it's ready to do some work. So we see about 20 to 30 patients each per day. 30s on those crazy days where we're coming back from a holiday. We got emergencies left and right. 20s usually on those days where we're going into a holiday and everyone's on vacation, no shows us. So it's usually pretty busy though. So total office, you're seeing 40 to 60 a day between the two of us. And then everyone always asks me because we have no assistants and just us, like when you take lunch, we just take lunch whenever. Take a little 5-minute break here between patients, and we're ready to rock and roll. So I guess we'll just roll right into the cases here. Just kind of a little heads up, I've never really made a PowerPoint like this before, so I kind of threw this together. I have a bunch of, they're all pictures that I've taken in the office. Nothing's gonna like show off who a patient is or anything like that. But I'm not the greatest at taking pictures, so if I have a good picture, it's pretty rare. But if you have any questions about anything, please let me know at the end. I kind of like broke these things down into like the different specialties that we kind of do. So one patient, I'll start off with like a real kind of basic case here. We had this 7-year-old come in, and he's been a patient for a while, but they kind of took a break coming to the office, and they came back and the kid was in a lot of pain. So if you look at that pan x-ray in the middle, you can see tooth S down on the bottom right, the patient's right. It's huge. It's basically blown out. The tooth is gone. Huge infection underneath it. So, we had to help him out. So we gave him some antibiotics. I'm pretty sure it was an amoxicillin, like liquid suspension. And then we ended up extracting tooth S, and he was fine. It's a really good patient. He's easy to work with for a 7-year-old. And then basically what we did was we took a scan then of his mouth. And in a scan, I'll show you a picture later on of the scanner we use. It's a 3-shape scanner. Basically, it replaces taking regular impressions. There's a lot of digital dentistry that I do now that my dad didn't have in the past, and I'm kind of implementing all that at this point. So we took a scan after extracting the tooth to make a space maintainer, just because this tooth, what is that? It's going to be 28. It's really not going to come in for a little bit. It may take like a year or so. So we want to make sure that the teeth on the lower right don't start collapsing in to close that space off. So we made the space maintainer, sent it to the lab to scan, and they fabricated one for us. So it's basically a band and loop appliance. So there's a band that goes around, which is tooth T, and then you have the loop that basically holds the spot and presses against the baby lower right canine, and that's it. So we cemented that into place. We use a special cement that can absorb a little bit of water. So especially in like kids like this, it's tough to keep everything pretty dry. So using that cement, it kind of helped us make sure we got that locked in there while he's kind of fidgeting all over the place. So we'll keep this in there until once you see a little bit of tooth poke out between that loop of the appliance. Once you see that, then you kind of have to monitor it a little more closely. And once the tooth looks like it's really can't come any further because of the band around tooth T, then you remove the band and loop appliance and you let the tooth erupt naturally. Then it should be good to go. One question the mom had asked us too is like, is there a chance that he loses tooth T, that lower right molar with the band around it, before 28 comes in? It's really not a concern. You can see tooth T has some pretty good roots and everything, and now that there's no tooth above 28, it's gonna come out of there pretty quickly. So that the cast that the space maintainer's on, that's like a 3D printed model. So that's what the lab uses whenever they receive the scan. They'll kind of virtually plan everything, and then they'll 3D print the model. So that's what we get a lot of now, these different models. And we have a different lab that for ortho stuff than we do for regular restorative and everything else. So that's what their models look like. They're like orangey yellow. I don't know. So that's just kind of like a pediatric ortho case, kind of transitional dentition, where you're kind of transitioning from a primary dentition to a permanent dentition. So it's kind of in the middle. You don't really want to do any crazy ortho yet, but you got to kind of give him a chance to grow into at least a good spot if you can correct other things. So the next case, what we got here? So this is a cross case. This is a classic just bridge case. So this is a patient that she presented to the office with missing teeth 3, 4, 13, and 14. Um, so she's been missing these teeth for a while. You can kind of see on the pan X-ray how the sinus it's pretty low in those areas. And the one thing she kind of came to the office wanting was implants originally. And so we took a pan, and it looks pretty low in that picture, but sometimes it's a little deceiving. So then I took a cone beam, a CBCT, and that gives you that 3D image of the skull. You can really see cross section of the jaw, and you can really see kind of how much bone is there for sure. And that revealed that she really was not a good candidate for implants. So the next best thing would be a bridge for her. It was either that or partial denture. She wanted nothing to do with the partial because it was removable. So she's like, give me something fixed, a bridge will be fine. So, in this case, one reason why a bridge is a really good option is because if you look at those back molars, so was that molar 2 and 15, they have huge fillings on them. So those are big, like old amalgam fillings, silver fillings. And then if you also look, you have like teeth 5 and 6, and 11 and 12, they also have a lot of fillings. So the bridge is acting in a sense that it's going to kind of hold those teeth together and protect them, as well as replace the 2 missing teeth on each side. So one thing we did was we took the one bridge, and you can kind of see our models here of the preps, and then the final product. I don't have like an in-mouth picture for this one. This was about a year and a half ago, so I really wasn't thinking about taking pictures of stuff. So you can see we went basically, we did a 5-unit bridge on each side. Now, the one question that the patient had for us was, why are we doing a 5-unit bridge when we only need to replace 2 teeth and there's 2 teeth on each side? So, that's 4 teeth, but with a large span bridge like this, we want to be able to make sure it's strong enough that it's going to withstand the forces, especially with the back molars being missing. They're going to take the brunt of the force of the bite. So we got to make sure it's as strong as possible. Also, with those anterior teeth of the bridge, the premolar and the canines, they weren't in good shape, and they were a little unstable. They weren't, they maybe like grade 1 mobility, so you can wiggle it a little bit, nothing crazy, but by kind of connecting those 2 together, it made everything a little stronger and more solid. And we just saw her recently for, if you look at that her lower left, so you see this one root canal tooth had a post, a core, and a crown. That tooth just kind of broke in half. So this was a patient that our first time seeing her was for these bridges. So I don't know who did the other dental work, but something happened with that tooth. It was kind of getting deteriorated, and it ended up breaking. So what we did was we extracted that lower premolar number 20, and we're doing another bridge now. We took that crown off of number 19, and we're doing a bridge from 19 to 21. So she's actually coming back soon to get that. So yeah, it's just a kind of a classic bridge case, but it's kind of a life-changing procedure when someone can't, they're not a candidate for implants, because it's something fixed. It feels like their natural teeth again, and it's not something that she's going to be taking in and out and getting food stuck under. And the biggest thing with partials are they're relying on the other teeth, so they can kind of speed up the deterioration of those other teeth, and just the constant in and out torquing of those teeth, it makes them a little looser, and that can be a problem. So we'll go to the next case here. We got, so this is like an endodontic and prosthodontic case. So we had this patient, was a new patient, came in with a large abscess. So we took this pan. I mean, you could see their face was, upper left side was blown up. It was huge. He was in a lot of pain, couldn't bite down at all, just throbbing, couldn't sleep the last couple of days. So he finally decided to call us. So when we took the pan, you don't see too much in the pan. The problem tooth is tooth number 12. So you might be able to see a little bit. The picture's a little small to look at that, but I took a PA then of the tooth, and so the picture with the yellow circle on it, that's kind of showing the abscess above the tooth, and it was pretty early stages of it. but it blew up pretty big. So you can see like kind of that dark area, that kind of periapical radiolucency, as they call it, at the tip of the tooth there. So first thing we did was we threw this guy an amoxicillin antibiotic, and we told him to take like, I think 4 of them right away to really calm this thing down, because we couldn't, we weren't going to work on it that day. So we brought him back in about, I think it was like 2 days, and his face looked 10 times better. It was much flatter. He said he was sleeping again. He felt great. Whenever a patient tells you that, don't believe them. They still have to get the root canal. Okay. People love to like feel no pain again, and then they don't show back up. This guy was all about getting things fixed. I think his wife was kind of pushing him to come back in too. The picture on the far right, then you can see, we ended up doing the root canal. So this was tooth 12, had 2 different roots. That tooth commonly has 2 different roots, and it commonly has a furcation, like almost like a molar furcation. So a lot of times you'll see like this tooth split from buccal to lingual, from front to back. It'll just split in half. And that's a big problem with these teeth. In this case, it didn't split. It had an infection. So it had a large cavity. An old filling was in there. If you see like that kind of blotchy white on the PA, yeah, I don't know what kind of filling that was. It wasn't good, but it was kind of in pieces, and I could see right into the nerve basically. So did the root canal. See the 2 canals there. We basically instrumented everything out, and using little files. And we use a rotary instrument as well. I should have put a picture of that in here, but it's basically just a handheld machine that basically files for you, just kind of help guide it in place. So we use that as well. And we built the tooth back up then. So you can see that huge white filling, that's all composite. And then that little gap between the actual root canal filling and the composite, we put a little bit of Teflon tape there, and that kind of seals off the top of the root canal. So if ever there's a problem, with that filling or anything, we can get into the root canal again, and we know exactly where it is, because we'll kind of run into it with our drill. We'll run into some Teflon tape. They'll be like, oh, guess we made it. Okay, instead of just kind of hunting for it again. So built the tooth back up, and what I have here. Oh yeah, it was a 2-visit root canal. So we cleaned the tooth out fully first, and then we placed calcium hydroxide in. And what that does is basically just kind of kills off bacteria. It has an antibacterial effect, a bactericidal effect. It also kind of stimulates cells in the tooth to kind of help reform a little bit in there. So it really just helps the healing process of the tooth. So second visit, then we brought him back. We cleaned it out again. We used a lot of irrigation using sodium hypochlorite, and we used some chlorhexidine too. And then at the end, we use some smear off as well. It's just kind of 3 things that we inject into the tooth and irrigate it out, flush it out. And then once that was done, we just dry the tooth off. We use these little things called paper points. They're basically just little pieces of paper that are in the shape of files. We stick them in there, it dries off the canal fully. And then once that was done, we filled it up with the gutta percha and a little bit of sealer on top of the gutta percha. So once that was done, we wanted to do the crown. I recommended a crown for him just because the tooth was basically 90% filling at that point. So you can see our 3D model there that was printed by the lab. And, you can see the crown. That's the crown prepped. So, the picture right below that's in the mouth crown prep as well. So it's easier to see on the model, like the margins that we create when you do a crown prep. So the biggest thing is, there's like a couple of principles when you do a crown. You want to make sure the walls are parallel to give the crown the best chance of staying on. If you make it like a teepee, the thing can just rock right off. If you make it parallel, the crown sits on, you really can't manipulate it much. Another thing is you want to have enough reduction of the tooth so you can, whatever material you're using to restore it, you have enough of that material bulked up so it's strong. So in this case, we made a zirconia crown, which is like a kind of a hybrid between ceramic and metal. There's no metal, showing in it, but it needs to be a certain thickness. So you can see I did like a shoulder prep. So, it comes down and it kind of slopes like this, and then there's a nice little shoulder there that the crown sits on. And, the biggest thing is when you get the crown, you want to make sure the margins are nice and smooth. There's not going to be a big bump out where the crown meets the tooth, and that's just going to trap plaque, bacteria. You're going to get a lot of inflammation, and you can also get another cavity in the tooth, and that's how teeth start breaking. And then patients go, "Oh my gosh, but you restored the tooth and it broke." Well, that's why. So then you can see the picture on the right. There's the crown at delivery. The gums are a little inflamed because I had a lot of it was going pretty low below the gum line. So when I took the temporary off, some of like the temporary cement, the temp bond, it just sparked up a little bit of inflammation in the gum. So that clears up in like a day or so. And that was it. So, when we deliver that crown, we put it on there. If it seats, that's good. That means the contact's pretty good. We'll check the contacts with floss. If floss can get through it pretty good with a nice click, but without tearing the floss, then it's golden. If you're getting to a point where you're trying to put floss through it and it's not going through, or you're getting through but it's ripping the floss, it's not good. Nobody wants to floss their teeth and go through 10 pieces of floss every night. It's a problem. So you gotta reduce with the diamond burr the contact area. And then we check the margins, and then the last thing I do is I check the occlusion. So I'll have it in there without cementing it. I have the patient bite a couple of times on occlusal paper, and it will leave a mark. And one thing that I've noticed, over my 2 years, but my dad's been doing this for 32 years. And one thing that he told me is always ask the lab to put the tooth in light occlusion. Labs seem to always like to bulk things up a little bit because you can't add to the crown once it's done, but you can reduce it. So if you ask for light occlusion, usually the occlusion is pretty spot on. So we don't really have to reduce many of our crowns. And usually at this appointment, I don't like to numb up the patient because I want them to be able to feel the crown in their mouth. And even if the occlusion looks good on the paper, sometimes it just may feel weird to the patient. It may feel like they're hitting it just barely first. So you want them to be able to feel that. It's kind of annoying when you send someone home and then that night or the next morning you get a call, emergency, I'm in a lot of pain, it kills when I bite down the tooth. That can happen when the occlusion's high. You're basically banging on the tooth and banging on the ligaments that are holding the tooth in. What that does is it just makes inflammation in those ligaments, in the PDL space, the periodontal ligaments, and it's basically it hurts to bite down. So the only thing you can do then is reduce the occlusion, make it right. You can have the patient take some anti-inflammatories, and you just got to give it some time to heal. Tell them to kind of stay off it. But if you reduce the occlusion to start with and make sure it's good, you shouldn't have that problem. It's the same thing goes with fillings. You can have a high filling and it can feel like the tooth needs a root canal, but no, it's just the ligaments are a little inflamed. So you got to adjust that. So that was a cool case. That was I think 2 weeks ago, actually, we just finished with that guy. He was pretty happy. So what you're not seeing is the other side of his mouth. He's missing 4 teeth and 3 of them are broken in half. So we got to work on that next. But all right, here we go. So here's a cool case. So this was a patient that came to us. He had a current complete maxillary denture. So you can see his denture in that top left picture. And you might notice that the palate's missing on the denture. So we did that because he couldn't stand the denture anymore. It was making him gag. It was causing problems. He hated the way it felt on the roof of his mouth. He was just overall very sad because they took all of his teeth out this other office. And he really didn't want that. And now the denture, he hates it. So most people really don't like dentures. So what we decided to do was we took a CBCT, and he had a good amount of bone in kind of his anterior maxilla, enough that we could fit some good sized implants in there. So what I do for that is, you can see that bottom left picture is we take a CBCT. So that's where we kind of check out the bone and everything. And that was me kind of planning out the case. The next thing I do is we have a company that is through the implant company that I use at the office. So I place BioHorizon implants, and they use this one lab down in Texas, and they can kind of help you plan these guided surgical cases. So what they did was came up with their plan. It was pretty similar to what I wanted. They just made some tweaks based off of where the sinus was and where the most ample bone was to use. So they send me a report back, which is basically like a video. And they're kind of, it's just like this, they're kind of having a presentation on for me and talking to me. And they kind of explain what they want. And if everything's good to go, we'll go ahead and order the guide. So you can see the guide, and it's in both top pictures. One of them's in the patient's mouth, and the other one's just kind of sitting there, blood all over it. It's a pretty bloody surgery when you do this stuff, but it's a lot of fun. So with the guided surgery, you can see that we have to use these 3 pins basically. So you put the guide fits in the mouth basically the same way the denture does. So you have to scan the denture when you send this to the lab, and they can basically fabricate the guide to fit like the denture. And they can also plan them where the implants will be hitting into the denture. So, once you get the guide and we're putting it in the patient's mouth, you have to have someone has to hold it in there, just how the denture would fit. And then there's these 3 pins that stick straight out. You can see the 3 pins there that are sticking straight out from the patient's mouth. And those are called anchor pins. So this is like, it's kind of scary at first because you have this like 24 millimeter pin. And you're like, this is going to go into the guy's jaw and not go in his brain. But in reality, the guide comes out pretty far. It's all calculated. So you get the pins in there. You drill a little bit, get the pins there, and that anchors the guide into the patient's mouth. One thing you have to do, especially with his case, he has very tight lips, and we had to keep making sure those anchor pins weren't popping out because he had so much force of the lip pushing down on the guide that the guide kept wanting to come out, and the anchor pins were all over the place. So my dad kind of had to be there that whole time, kind of holding those pins in while I was doing actual surgery. Then you can see there's one implant that's going into that middle implant site in that top picture. And that's kind of like right after I was torquing it to depth. And that's basically all it is. I mean, you go through these protocols with these guided surgeries, and it's pretty self-explanatory. It's a lot of pieces you're looking at. And I should have put a picture of the surgical guided kit in here because it's just like there's things all over the place. But it all makes sense when you actually like do it once. And then you can see the pin at the lower right. That was right after surgery. So I took that just to kind of make sure things were down to proper depth, just because the guy was kind of being weird and it wasn't fully tight all the time. And I think we ended up going back, and that patient's top left implant, we sunk that a little further. But you can see we're nowhere near the sinuses. We basically used where all the bone was. And then one thing I don't have a picture of is, we waited 4 months for the implants to integrate, and during that time he was still wearing his denture. So we relieved the denture, the inside of it, so nothing was hitting where those implants were, so they could have optimal time to integrate without anything bothering them. But then after the 4 months, so what you have to do is you order some parts. You have to uncover the implants. So you basically cut open the gums again, uncover the implants, and put healing abutments in. So healing abutments are basically little cylinders that attach to the implants, and they hold the gums away from the implant basically. So you can then access the implant whenever you want. So we give that like a week or so to heal. And then once that was done, we measured how deep the gums were to the implant. So the implants are at bone level, these implants. But one thing for an overdenture is you have to have a piece, which they call the male component. It's a locator abutment that connects to the implant, but it needs to be sticking out of the gums a little bit so then it can connect to the denture. So you have to measure how deep the gums are because they sell these things in different heights. It's called like a collar height. So the part that's in the gums is the collar, and the part that sticks out is the actual like locator. So in his case, I think 2 of them were like 3 millimeter collars, and then one of them was like a 6 millimeter collar. So we kind of had to order different parts to make sure they all came out the same spot. And then once we had that stuff in, we basically brought it in for a longer appointment where we took the healing abutments out, put those locators in, and then you have the female component, which is the housing unit that goes into the actual denture. So what you do is, you connect the housing unit onto the locator. They snap in. They have different kind of rubber gaskets in them that have different strengths. So for his case, he's older. We gave him the weakest one, so he's able to get it out. And even the weakest one, I mean, we couldn't even get it out at first. It's pretty tight. So you hook them onto the implants, and then you draw a Sharpie on the top of the housing unit, and then you put the denture in with the dry just to kind of make a mark. And that Sharpie kind of leaves a little bit of a mark on the inside of the denture. And that's where you know that you have to basically cut a little hole in there. You have to open up so the housing unit can fit into the implant without it sticking out of the implant, or put it into the denture without it sticking out of the denture. So once you cut those holes, then what you do is you fill the denture and around the housing units in the patient's mouth with acrylic, with denture acrylic. And then you seat the denture in there all the way, make sure it's fully seated, and you have to wait for it to set. And then it's kind of like the moment of truth where it's like, you got to rip this thing out of the patient's mouth, and hopefully the housing units come with the denture and they're not staying on the implants. So, we took us like, I don't even think I got it off. This was like a year ago. And at first you always want to be gentle with patients. And so I'm having a hard time ripping this thing off. And my dad came in and he's like, is it not coming off? I said, oh, it's not really coming off. It's like, you want to give it a try. So he just grabs it and rips it out. And the patient's like, but it's just a lot of force. So we got it out. You trim up all the excess stuff. And then that's it. You snap it in there. You have to make sure the patient's able to take it out when they have to clean it still. And this guy, took him a while to get it out of there. and but he is ecstatic now. I mean, he's so happy. He was like crying a little bit at the delivery, which was great. So then once we gave him that denture, kind of the newly fixed denture, we took away more of the palate. So now he really just has no palate on there, and he loves it now because he feels like it's much more normal for him. Now he's already asking about taking out some of the bottom teeth and doing implants before he loses the bone. So it's a whole new story now. But that's like a guided case. They're pretty fun. You learn a lot through all of them. This was, I think, my third guided one, so I kind of had the general gist of things at this point. But it's always like, I don't know, we always go into it like, what could possibly go wrong? There's things like, the denture is not seating, guide's not seating right. The bone is very dense, not drilling properly, all this stuff. But you figure it out. Let's see here. So this next case is just an oral surgery. It's like a full mouth extraction case. This patient came in, 70-year-old patient, stating, "I want all my teeth removed." That's literally what she said. We take a pan and we see that all of her teeth, meaning her 6 teeth, they're very loose, very infected. If you look at the one tooth on the patient's lower right, the second from her lower right, you see this big kind of white blob off the middle of it. That's all buildup. So if you look in the picture on the bottom, that's all the teeth when you took them out. The tooth at the top of that picture, that's buildup that's hanging off that tooth. I mean, I've never seen that much buildup before. And going to school at Temple in Northfield, you see a lot of stuff. I didn't see that much before. So we pulled all the teeth. It took about like 5 minutes. I mean, these things were like flicking out baby teeth. It's just like I couldn't take them off my fingers, but I use instruments. So you just grab them and kind of with these anterior teeth, you kind of just twist and pull up, and it kind of breaks all ligaments and you pull it out. We gave her antibiotics to take kind of post-operatively for the next 7 days. And she was thankful. We'll probably never see her again. She came one time and it was just for this. So we'll see. Her husband was also there, and he had no teeth and no denture as well. So it's kind of, there's a trend going on. The biggest thing is you can't force things on patients. So it's, make them happy as long as it's something that you're ethically okay with. And, in this case, everything was infected. It had to go. So we helped her out. Here's a kind of a PROS oral surgery case. This is an immediate partial. This patient, he was a patient of my dad's a while back, and he shows up out of the blue again. He had a current partial denture, which I don't have a picture of here. But his problem was tooth number 8 was hurting. So that big white crown he has that matches nothing, that was hurting. There was a huge infection below. We took a PAM, we took a TA. You can see those x-rays. You can see all that dark area. It was super loose. So again, we gave him antibiotics, and he wanted to remove it. So the biggest thing with that was he had a current partial, and it wasn't replacing that tooth. So we had to make him an immediate to replace that. So you can see the immediate in the middle picture there. That's the kind of the 3D printed model in the immediate. And so what we did was before you take out the tooth, you scan the case or take an impression. And you send that to the lab so they can make the new partial. And you basically tell the lab, I want an immediate delivery, replacing all these teeth, including tooth number 8 in this case, which will be extracted at delivery. So the lab basically just kind of virtually knocks off that tooth. They print the model, and then they fabricate the denture. In this case, we made a Valclast partial. That's what he had before. It's all kind of a Valclast, like special acrylic material. There's no metal in it. It's pretty aesthetic. And then we brought him back once we had the case in our office. We extracted the tooth. You can see that picture after the tooth was extracted. I mean, that tooth was pretty nasty looking. And I sutured him up, and then that same day, we put the partial in there. Now, the partial, it looks weird. Trust me, this dude wanted an exact replica of his current partial, which he's had for like 10 years. So, no question. I tried to convince a patient once before to make a partial more aesthetic for them, and I gave them that, and they were pissed off because they wanted something that looked like their old one, which didn't look good. So I've learned that if a patient wants something, just it's their mouth. Let them do what they want. So he was super happy. You can see that you can barely see that Valclast clasp on the front, and especially I was pulling the lip up there when he was smiling naturally and lowered his lip. You really only see half of the teeth, basically incisal to like the middle. So it looked pretty natural, and he was happy. So we'll see him again probably for another emergency at some point. So this is the slide I was looking for. So things I use kind of every day was Those are my loops in the top left. So, I use they're oroscopic loops. I forget what they're called. I think they're called like the ergo somethings, like 3.5 or 4.0 magnification. I got those this past year. It really helps because I'll be practicing now, like sitting straight up and I'm looking that way, but really looking this way. Whereas before with my old loops, I was still, a little bit hunched over. And it's a lot better. I kind of, I was getting a little bit of just neck soreness and back soreness. And now it's really, my posture is great. Even if it may not look great right now, but it's good at the office. The top middle picture, you can see that's my scanner. So that's our 3Shape scanner. And we have a little cart with that on, so we can kind of move it between rooms. It comes with a laptop and everything. And the picture on the right, that's like just kind of like a scanned case right there. So, that guy had a lot going on the top, but I only put that in there just because you can see like we did a 4 crowns on the bottom for him. And that's just kind of what it looks like when you scan it. You can move this thing all around the screen. You can zoom in, zoom out. You can do whatever you want with it. I marked the margin lines for the lab. So it's awesome. So it's really cool to use. And then just something we've been using for the past year, acrylic wise, when we're doing fillings and stuff like that. It's this stuff. It's called like Omnichroma. I'm not like a salesman or anything. I really, we kind of just go with whatever gives us the best price and whatever works well. So this stuff though works really well. It's pretty cool. So it comes with a flowable and like a packable type of composite. And the best part is it's kind of like it has like a chameleon effect. So if I'm doing just a regular filling and I'm not really worried about anything kind of on like an incisal edge or anything, I'll just use this. It looks like it's pure white when you put it in, and you cure it with the light, and it looks exactly like the tooth because the tooth kind of chameleon and like shines through it almost. And it's awesome. You don't have to like get your shake out every time. You just do this and it works fine. If you're ever doing like a class 4 filling, which is basically like if someone breaks their front tooth in half and you have to basically build up half the front tooth. One thing you can't do is you can't just use the regular stuff because you'll see like the darkness from inside the mouth showing through the filling, and it will look weird. It'll look like if they have like a gray half of their tooth. So what you do is you use that middle stuff there, blocker, which is basically a radiopaque. I don't know if it's not radiopaque, but it's solid. It's not translucent. So you put that on the lingual aspect of your filling like that. So, and then you can use the regular stuff on top of that. So then you don't see any darkness from inside the mouth, and it still kind of blends in with the rest of the tooth, and it works pretty well. So that's just kind of like fun stuff we use. It's good to, this is a video. I didn't even know that. Here you go. So you can see kind of, I'm moving around. His top denture is crazy. He was like missing a front tooth as well in that thing, but he didn't want it fixed. His bottom teeth are also atrocious. So the preps are they're all over the place, but it was an interesting case. All right. How are we doing on time? We're doing all right? I think I got like 2 more cases left. So here's an ortho case. So my dad does braces. I don't have any pictures of that stuff, but here's an Invisalign case. So I first started using Invisalign right out of school. They were good for a while. It's just, they're really, when you start kind of looking into the actual like money of a dental practice, you gotta figure out where to cut costs. And in this case, Invisalign is really expensive, the lab fee for it. I mean, you're talking like for a complete case, like almost $2,000. And it's just ridiculous. So I work with a company now that's a little less than, actually a little bit more than half that cost, and I'm getting the same results. But that's another day to look into that. So this is an Invisalign case. You can see the patient had pretty extreme crossbite in the front and the maxillary teeth, and on the bottom too. All the pictures on the left side, those are before, so you can see kind of the maxillary from the occlusal view. It's just everything's all over the place, a lot of crowding. The crossbite's terrible. The guy never really smiled. He's a young kid. He's like 15, 16 years old, going into high school. He's pretty embarrassed. His oral hygiene is also terrible. We won't mention that right now. He's getting better at that with the teeth being a little straighter too. But then he was in Invisalign for a little over a year. I want to say it was like 13 months. And so that's where we kind of got him to at the end, the whole right column. And I mean, as far as lining things up, it really turned out great, better than I expected, honestly. I thought we were going to have to do a lot of revisions, which is basically like ordering additional trays, but I didn't need anything. He was pretty religious about wearing the trays all the time, and it really worked out awesome, in my opinion. I mean, one thing that we could have done at the end is kind of lowered the maxillary teeth to create a little bit of more natural overbite, But in his case, everything was because of his hygiene and because of all the inflammation, everything was unstable at the end. So we wanted to just kind of put him in retainers and keep him there until kind of the bone solidified, everything stopped remodeling. And, we told him that we can kind of resume his case if he kind of gets his hygiene in check. We can kind of fix some minor stuff here and there. So he was ecstatic about the case. He was really happy. So that's a fun Invisalign thing. It takes like 15-minute office visits. You kind of see them like every month or so. I mean, some people probably here have Invisalign, so it's awesome. Works really well. Here's a cosmetic case. So the old bridge is ugly. I think I got tired of the PowerPoint at this point when I was writing this. But this guy came in. He was a Spanish-speaking patient, and he came in. He's like young. He's like 25 years old, but he had this old bridge. You can see it's from 7 to 10. He got this done in his country when he was super young. He knocked out his front teeth. And he got this bridge put in. And it's almost like the dentist who did it just didn't know the difference between like a lateral incisor and a central incisor. So they put the centrals where the laterals were, and they put the laterals where the centrals were. So it looks like he's got these two little tiny front teeth. It was hilarious when he finally decided to kind of get a new one made. I think I have a little typo in there. His name's not Ted. I don't know why I wrote that. But so we basically destroyed the old bridge. We drilled that off, kind of cleaned up the preps a little bit, and then we made him a new one that actually was anatomically correct. So that was kind of like trying in the bridge in that bottom picture. I think we adjusted a lot of stuff on because the lab somehow like canted the bridge a little bit. You can probably see like his left side's a little lower. I don't know how they managed to do that, but we ended up kind of adjusting the incisor edges and making it, look even and everything. And he was super happy. So I think he brings a lot of his family here now, which is a good thing. Patient referrals are awesome. And this is just a fun little case. Just like, this is a classic like oral surgery case that we do at the office. Patient presented, he said that his molar smelled bad. He was getting a bad smell and taste on the left side. So he thought that he had just needed a cleaning. I looked in his mouth and I was like, this is a lot more involved than cleaning. So then I took an x-ray, and you can see on the x-ray, this dude, his total root was demolished. There was a huge infection above the tooth. That's why it smells. I mean, there's bacteria just accumulated in there, and it smells and tastes terrible. So that day, it was part of a bridge. So what we ended up doing was I sectioned the bridge, which, so you have an abutment crown, which is on that back molar, and you have pontic, which is the floating tooth. Then you have another abutment crown. So I sectioned it between the pontic and then the tooth that we were keeping. So just you drilled it in half. It takes a couple burrs to get through because it's metal. But I drilled that in half, and then once I freed the back tooth up, it kind of just like fell out. It was only being held in there by the bridge. So, we took the tooth out. You see the picture of it there and just how obliterated it was. Placed him on antibiotics, and then called it a day. So I think he wants to come back eventually to get an implant, potentially in that spot of 14 where the pontic was in the bridge, so we can kind of give him his bite back. But that's kind of just a fun little oral surgery case. And let's see. So this is another case we did. We do just like single site implants. So we do the guided cases, but also we do some single site implants here and there. It's really whenever I do an implant case, I'm not an implant surgeon by day, so I'm not doing implants every day. So, I pick the cases that I'm comfortable with, and if I'm in any way, shape questioning my ability or the case in general, I'll refer them to the oral surgeon, and they can handle it from there. We have a great relationship with our oral surgeons in the area, so it works out fine like that. But in this case, a patient came to us. He cracked tooth number 30 in half. He had a big filling in it, and I don't have a picture of the X-ray or the tooth beforehand, but we extracted the tooth, and we ended up letting that socket heal for about two-ish months. And then once we took a CBCT and solid bone was pretty good for us. So then we went in and we placed an implant. This is just the stages of the implant. So we did our initial osteotomy, which is drilling through the bone, making sure we have the right kind of angle of attack and everything going in there. So that first picture on the left of the x-rays, that's kind of like our guide pin. You put that in there and make sure that things are lining up right. You don't want the guide pin to be too far one way, too far that way, too far front, back. Try to get in the middle. The next picture from that's the depth gauge. So you take another x-ray, and all those kind of indentations on that, they have a different meaning. In this case, this was a 12 millimeter implant. I kind of remember this one. So we wanted to make sure that we got the depth gauge at the top of that, kind of like that bump out bar in the middle, which is, we were basically there. I think after I took that x-ray, I ended up drilling like another like 0.5 millimeter down. And then we ended up placing the implants. You see the implants in there. It's nice. It was in level with the bone on the x-ray. In person, it was a lot. It was more like 1 millimeter like sunken into the bone. So it was pretty good. And then that's the healing abutment on the top of it. So that's like the piece that holds the gums away. So, you wait 3-4 months for that to integrate. You kind of torque test it when you bring them back in, take a couple x-rays along the way. And then you get the crown made up. And to make these crowns, now what I do is, since we have a scanner, we have what's called scan body. So you take out the healing abutment, you screw in a scan body, which is it's either like plastic sometimes, or it's a metal piece that sticks out of the implant and out of the gums. You scan that, and then the lab basically knows what that scan body is, and they have it in their computer software. So then they can basically superimpose their scan body in the computer where mine is on the scan, and they can virtually place the implant, and they can make the crown off of it from there. So that's kind of how that works without doing a traditional like infragum impression. That was it. All right, we did pretty good there. So I guess any questions, and go for it.
Yeah, so we can start a Q&A session. So, and if anybody has any questions, you can just directly put them in the chat, or if you want to send it to a doctor's private chat too, you could do that too. We do have one question. It's, how did you like the 3+4 undergrad to dental school program? Would you recommend it to others?
Yeah, no, it was good. For me, it was good. I mean, I had a great time in undergrad. It was a lot of fun. But being able to kind of knock an extra year off of school, it's a long journey, dental school, and especially if you're going to do like a residency after that, it's a lot of years. So I think if you can save a year, save that money, and kind of, get out and start working a little sooner and live your life, it was good. It was good for me, and I don't regret it. So I think when I was at Temple, they were saying like there was like so much 3+4 students coming in over the years that they were almost like gonna like slow down the program or stop it. I don't know if that ever happened, but I mean, definitely people are taking advantage of it because it's a pretty good program. So yeah.
The next question is, did you do CE courses for implants and other more advanced dental procedures, or were you taught those things during dental school?
Yeah, so in dental school, when was that? Like maybe our 3rd or 4th year during classes, you do a couple implantology courses, and you go over the basic, the biologic stuff of it, all the bacteria and all the boring stuff of it, and then you don't take any like actual placement courses. So you learn how to restore them. You learn all about keeping them clean and keeping them in people's mouths, and when to place and all that stuff. But you don't actually learn to place it. So what I did was, after dental school, I think it was like 2 months out, I just was kind of looking at different courses in the area, and I was approached by, I think it was actually Hyacin, which is an implant company. And they approached me, and they were like, look, like, we'll give you half off this introductory implant placement course, and you get some live implants and everything, and bring your own patient at the end. So it's cool. So I did like, I think it was like a month of like couple nights a week, like nighttime Zoom classes like this, going over everything. And then we met in person for like a hands-on training on pig jaws. So we placed about like maybe 5 or 6 implants on pig jaws. And then maybe like a couple weeks after that, we were able to bring our own patients into one of the doctors who was helping with the program's offices, and they kind of oversaw us do actual live surgeries then. And that was it. So I mean, I think I only did like 2 or 3 live surgeries before I was kind of on my own and doing it in the office, which is one way to go about it. I have other people that I went to school with that they went, abroad, and they placed 150 implants over a weekend in like, Puerto Rico or something. So you can do that too. It's really whatever you want to do. I just did it this way because it kind of came up and it was convenient for me. But anyways, good. But definitely, I would highly recommend, taking extra courses like that with stuff that you're interested in. The biggest thing is you just got to stay in your scopes. Like I pick cases that I know are like slam dunks. I'm taking CBCDs. I know how these things are going to turn out. There's no questions about the case. If there's any questions, I refer it out. And, as you do more there, you get better. So I'm seeing cases that I used to refer out that I'm doing now. And it's only been, a year or over a year since I started placing. So it's pretty good.
Your next question is, what was the transition from dental school to work life like?
The transition from dental school to work life. For me, it was pretty easy. So during dental school, I was working on like those random Saturdays with my dad. So like, I don't even know if it is like illegal, but like I was kind of working on patients that were like family friends and stuff, and that were fine with me working there. So I would have like a full, like 15, 20 patient load of cleanings to do. He'd only let me do cleaning. So I would do like 15, 20 patients of cleanings on some weekends. And that kind of got me up to speed. Because the biggest thing is in dental school, you see like 1 or 2, maybe 3 patients a day when you're in your normal clinic. In the office, you're seeing, 15, 20, 25, 30. So I kind of had that speed kind of ingrained in me during dental school. So it was good. So one thing, if whenever you're in dental school, work on your speed. At first, things take a while because you don't know what you're doing. But as you get more comfortable, you get faster, and try to just do as much as you can in as quick but as good as a fashion as you can. So the transition was pretty good. Plus, you're working, you're making money, so it's a lot more gratifying sometimes.
A similar question to the one from the transition from dental school to work life. How is the transition from undergrad to dental school? Any tips for future dental students?
So I was like one of those kids that was pretty smart in high school. Then I got to undergrad and I still like barely studied and got by fine. And then I got to dental school and I almost failed like biochem the first semester. I got like a 50 on the first exam, then like a 60. And I had to like really look in the mirror and like change something to be able to keep going. So the transition for me was rough. I just didn't really have any good study habits. I relied on like Quizlets all the time, which they're great. I still, I used to use them a bunch, but I learned that it just wasn't enough for me. So you kind of have to like go in there with an open mind and adjust to how you're doing things. Also, you're all in the same boat in dental school. Like, there's really, everyone's trying to pass. So if you can get a good group of friends that you can study with and you kind of bounce ideas off of them, it's really good. That was really the biggest adjustment. It was kind of knowing how to study. I just didn't know how to study, I guess. I was coasting by for too long, and then it kind of just hit me in the face all of a sudden. But yeah, class is fine. Then clinical stuff, you're in pre-clinic from day one usually. That's awesome. So you got a drill in your hand, you're working on your little dummy head, and that's a lot of fun. That's like recess. So you're in class for 4 or 6 hours a day, and then it's like you got like 2 hours of pre-clinic. You're like a little kid in the playground. It's great, just drilling things, and that's a lot of fun. But you'll be fine. Just come in with an open mind and figure out how to study, and it's time management. If you don't put the time in, it's really gonna eat you up. But if you kind of know you're gonna make some sacrifices with your social life for a little bit, it'll be fine.
Do you recommend working during dental school or full-time school?
I'm trying to think. I didn't have anybody in my class that I know of that worked full time. I did one Saturday a month. That was not, I don't even call that work. Another kid I think also worked for his dad. He was there some nights during the week, but he was just doing lab work. I don't think anyone was working. That would be tough. If you have to do it, you have to do it, for financial reasons. But it's time management again. So you're going to be really, really putting a lot of time in between school and work, and you're going to have to make use and kind of figure out ways to kind of speed things up, study wise, in order to have enough time to do it all. I don't know if I would recommend it, but if you have to do it, you have to do it. It's kind of the best answer I can give for that.
We have one more question. What was your favorite case that you have done so far?
Favorite case? Oh man. It's honestly probably that overdenture that I shared with you guys today. Just that was pretty early on in kind of the implant thing for me. But just whenever you see like a patient's reaction of how happy and grateful they are when you kind of finish off a thing like that was like a 5-month process. He was just ecstatic, and he still comes into the office randomly and just says how happy he is. I think that's kind of, I could say a lot of cases are my favorite just because of the reaction you get from people, and they're just super happy. So, but filler denture was fun. But I like anything drilling. I like oral surgery. I like pulling teeth. I like it all. Then we know hygienists, so we mix in the hygiene too. So like, we'll go from like ripping out 6 teeth to like doing a nice calm cleaning in a matter of like 20 minutes. So it's a good time. I don't know if I was getting anything from the chat.
Yeah.
I think I got the
These are all
chat,
the
right?
questions. Do you have any questions that you got in your chat, or is that it?
Let's see. Chat. Here we go. Oh, this is the big chat. Okay.
Yeah, that was it.
That was
Okay.
it. Right.
Okay, I think that's the end of questions, but thank you so much for joining us today, Dr. Psomiadis, and
Yeah.
to everyone who joined us on Zoom today. Your session was really informative and gave us insight into a lot of the cases and what you do every day. And also the attendance quiz will be posted later today for those who were not able to watch the live session. Again, thank you so much for taking time out of your busy schedule, Doctor. We really appreciate it. So thank you so much to everyone who was able to make it. We do have our next session, so just be on the lookout for that one.
If anyone has any other questions, you can find me on Instagram, or if I'm sure Crystal can give out my email or whatever phone number if you want to hit me up with any questions, right?
Yeah.
Cool. All right. Thank you.
Thank you.